following on those thoughts about BTK inhibitor-based therapy, there are second-generation BTK inhibitors that have been developed. The acalabrutinib was relatively recently approved for patients with CLL, and the data that supported that approval was recently published with the Elevate-TN trial. Maybe John Burke, you can comment on, particularly if you have any experience using acalabrutinib, what your experience has been in terms of efficacy and activity and tolerability of the second generations, particularly acalabrutinib. There's another one, zanubrutinib, which is approved not for CLL, but is approved by the FDA for mantle cell, which we also may have eventually available for CLL. So what are your thoughts on the second generation molecules?
Yeah, so if you want, I can kind of summarize the Elevate-TN data. These were presented by Jeff Sharman at ASH and then published in April of this year, I think in Lancet. And so this is a phase 3 trial that had 3 arms. The control arm was chlorambucil obinutuzumab, and then the 2 investigational arms were acalabrutinib alone and acalabrutinib plus obinutuzumab. And the patients were again, those similar to Illuminate and CLL14. These were patients that were either elderly or had the higher SERA scores and thought not to be sort of candidates for more aggressive therapy. And the primary endpoint was PFS. The median follow-up is just over 2 years, and the data showed that PFS with either acalabrutinib arm was superior to PFS with chlorambucil and obinutuzumab. There was sort of a numerical improvement in PFS in the combo acalabrutinib-obin arm compared with single agent acalabrutinib, but the authors were careful to state that that was not, that they could not comment on the statistical significance because that was sort of a post hoc analysis and not part of the primary endpoint. So, so I think, you know, in terms of toxicity, they reported a rate of AFib 3 to 4%, which again, as I just mentioned, is sort of similar to what we saw with the earlier follow-up with the ibrutinib trials. There's a lot of talk about how AFib rate, you know, may be lower with some of the second generation agents, and we have actually seen documentation of that in the phase 3 Aspen trial of zanubrutinib in Waldenstrom macroglobulinemia as compared with ibrutinib. That's the only randomized data that I'm aware of, and we're waiting on acalabrutinib versus ibrutinib randomized data to see if that difference in AFib rate really holds up. So, you know, I hear experts such as those on this call talk about how acalabrutinib is likely to cause less AFib and less cardiac toxicity. I'm a little bit cautious in drawing that conclusion myself and a bit agnostic on that. Bleeding rate in the Elevate-TN trial was in the 35 to 45% range. Again, the grade 3 bleeding rate was 2%, sort of similar to what we heard early on with ibrutinib. So the one comment on the acalabrutinib toxicity is a little bit unique that I think practitioners should know is headaches. And so if you haven't heard this before, headaches are relatively commonly reported with acalabrutinib. The data that I saw early on was that it was about a third of patients. I think there's probably more attention paid to that now, and I think the studies that are coming out now are saying actually about 2/3 of patients are reporting headaches. So how much of those are actually due to acalabrutinib versus the fact that people get headaches and they get reported, I'm not sure. But it certainly seems that there's a bit of a headache signal. It usually is manageable. I tell my patients to try caffeine and Tylenol and those types of things usually help manage the headaches, and most patients are not having to stop the drug because of intolerable headaches. So in my hands, it's been well tolerated. I haven't used as much of it as I have ibrutinib, but so far it's been well tolerated, and I haven't had any major problems. I did have one bleed in a patient who was forced to use it, you know, concurrently with anticoagulant. So there you go. I'd be real cautious about that.